in case you're wondering what this is. You do the questions, I'll do the answers. That's how it works. I've got some preordained questions. If you've got any questions of your own, you can chip in. And if I can answer it, I will do my level best to give you my opinion and my take on this stuff, because a lot of it is opinion. A lot of it is opinion. It is not written in stone, a lot of this stuff, which is why I do, pity is the wrong word, but sympathize with people who are looking for surgery, because there's lots of opinions out there. It doesn't mean someone's right and wrong. Plastic surgery is still one of those ones where there is individual surgeons who've got experience of something, and they will then do it that way, whereas another surgeon will have an experience of something else and do it another way. It doesn't mean that one's right or wrong. You know, some surgeons, you know, use a lot of teardrop implants, some people use a lot of round implants, some use smooth, some use textured, some use an inframammary incision, some use transaxillary incision. You know, some do liposuction with to the upper abdomen when they do a tummy tuck, others don't. And it's just the way it is. You know, people do approach gynecomastia differently. It's just opinions. So this is all my opinion. And it is not, I'm not saying it's the right way to do it. I'm just saying it's the way I would do it. And, you know, like, that's how I've done it before, and it's worked out all right. I mean, there is some, I suppose it's not quite as bad as that. I mean, there is some, like, you know, proper stuff behind it, you know, got training and all that sort of thing. So it's not quite as random as that, but there is still opinion in plastic surgery, as opposed to other types of surgery and other types of medicine, where there are sort of algorithms, like if your blood pressure's that, you do that, and then if that doesn't work, you do that, and that's second line, third line. You know, there's like these charts of stuff where you don't really have those charts in plastic surgery. So, right. Well, with that said, we've got to get into the first question, which is, can we remove a cyst located on the finger joint? So, I think we have a theme probably every week with a cyst or something that I can't remove from a certain area. And this week is the cyst that can't be removed from a certain area is the finger joint one. Now, I won't say it can't be removed. It can be removed. And this is particular patient who sent us a photo, who it's over the knuckle. And it's not uncommon to get them over this one's over this knuckle. It's not uncommon to get them over this knuckle, the end one, but it can be the end or the middle one, I think. And a cyst over a joint is a particular type of cyst. It's called a ganglion. And a ganglion is a little bit more difficult to remove than a cyst that will be underneath the skin, because it's connected to the joint, and they've got a very high risk of recurrence. And you would probably, you'd probably want a hand surgeon for that. Now, there are plastic surgeons who are hand surgeons. Hand surgery is a subspecialty of plastic surgery, would you believe? I don't know if that's news to you, but that is quite a major branch of plastic surgery is hand surgery. And certainly when you're training, you do an awful lot of hand surgery, a lot of trauma, people sort of cutting tendons and what have you. So that would be a hand surgeon. And when you do hand surgery, you do things like use a tourniquet to stop the blood, to make it easier to do the surgery. And so that is not something we would do at our clinic. We don't have a tourniquet. We don't really do hand surgery as such. I mean, I would take a mole or a tattoo or something off the hand, but that wouldn't be classified as hand surgery. If you're talking about surgery getting into the joint, one, I wouldn't do it at the clinic because I haven't got a tourniquet. And two, you know what, I wouldn't do it anyway because I'm not a hand surgeon. I'm a breast surgeon. So there are plastic surgeons who would do that. And also orthopedic surgeons. Hand surgery is a cross between orthopedics and plastic surgery. Both will do, probably both would do that sort of surgery for the finger joint. But high rate of recurrence, and a little bit more complicated because you have to do stuff, because you have to get down onto the joint. So yeah, that was a no, unfortunately. We'll do that one. That cyst on the finger joint. Now, I currently have a breast asymmetry and would also like an areola reduction. Can you help? Yeah, so this patient has, I think is thinking of having a lift on one side. So one breast is sitting lower than the other breast. And I think it was an implant in both breasts and a lift of one. And so if you have a breast asymmetry, it is usually / always pretty much the case that you'll have an asymmetry of nipple height. So you either ignore that or you lift the lower nipple. You wouldn't really want to lower the higher nipple. So when you've got an asymmetry, one breast bigger than the other, usually the bigger breast is heavier, sitting lower than the smaller breast. So there's an asymmetry of nipple height. So if you're going to try and balance that out, you would do a lift to raise that nipple up. When you do a lift, an areola reduction is an integral part of that. So if, as well as your asymmetry, your problem is the areola is too big, that lift will address that. But of course, if you're just having a lift of one breast and you're not doing a lift on the other breast, then you might have a difference in size of your areola. Excuse me, Georgia Bavista, yes, you can ask a question on here. So if you are doing a lift of one and not a lift of the other, if the larger breast hasn't got a disproportionately bigger areola than the other one, if you want both of your areolas to be smaller, that will be an integral part of the lift, but you'd have to do an areola reduction of the other breast separately. Don't know if I made that overly complicated. And then if you're going to do implants, that's fine. That's kind of a separate thing. But you can, so an areola reduction is an integral part of a lift. So if both breasts are sitting low and you're having them both lifted and your areolas are too big, that is just part of the deal. You get your areolas reduced as part of the lift. That is an integral part. But if you're just having a lift of one, you could separately have an areola reduction of the other breast, and then if you want to have implants as well or not, whatever, that's separate. But Georgia, yeah, that's the idea. You answer a question on here. It's interesting. We've had two of these. We've had this: can you remove an overdrawn lip tattoo from the skin? And we had another one today on the online chat, patient asking about eyebrow tattoo. Now, generally speaking, you can excise tattoos, and we do quite a lot of them. We seem to have quite a sort of big call for it. But I would always say laser is the first port of call, because when you excise a tattoo, when you cut it out, you give a scar. And on the face of it, I would say both of these, an overdrawn lip tattoo and an eyebrow tattoo, would not be good things to remove by excision. They're not ones that I would immediately think that would be great. Yes, we can definitely help you with that. We can, but I wouldn't like to go cutting out an overdrawn lip tattoo. I don't really know, unless there's sort of like a bit splodge or something. I don't know. But if the whole lot of the lip tattoo is overdrawn, I wouldn't want to give you a scar all the way along your lip. Personally, I think that would be potentially worse than your overdrawn. I mean, I haven't seen a photo of this, so you can always send us a photo. But same with the eyebrow. I would say, look, I would probably think about laser first line, because laser doesn't leave scarring, or at least less chance of leaving scarring. And so laser would be my first port of call for those lip tattoo / eyebrow issue. Georgia, what have you got? Georgia's coming in live on the gram. I was just wondering more about boob implants, rough prices, aftercare, etc. Thanks. Oh, I see. A question like that. I've got to be honest with you, Georgia. I don't know the prices. I think it's like probably a bit more than 6,000. I don't know. Do you want an exact price? I'm going to say 6,000 to 7,000. I think. I don't know if anyone's had, but what you can do, Georgia, you can either email us or message me your email address, and I'll email you. Or if you go on the website, you go on the breast augmentation page, and it says get price or request a price or something like that. Put your details in. You'll automatically get an email with all the information about prices and stuff like that, and aftercare. So rough prices, I'm going to say 6,000 to 7,000. Depends a little bit about surgeon. So we've got Costas and myself. So I'm more expensive than Costas because I'm trying to do the running and doing all this time-consuming stuff like this. Obviously, this Q&A stuff, and also the type of implant. So polyurethane foam implants are more expensive than silicone implants. So that's another differential in terms of the prices. But we can talk about all that sort of stuff. Aftercare, yeah, one of the big things about me and my clinic is that we very strongly focus on the aftercare, and I've always said I think the aftercare is at least as important as the surgery, and a huge amount of our time is spent on aftercare, because I think that's how we've framed and built the clinic. So you have a surgery on a certain day. You can often go home the same day as your surgery. You would have a dressing clinic appointment the week after with Vicky or Geraldine, one of the clinic nurses. You would have a follow-up with me about 6 weeks, check on the scar's probably a bit red, shape might not be quite right, get you talk about scar management, what have you. Then normally another follow-up at 6 months, 12 months, and then yearly. That's the sort of aftercare regime of it. The implants themselves have got a lifetime warranty. You'll be covered for 6 months for revisions. Revisions meaning that they're too high, too wide, too up, too down, whatever. Be a bit careful because revisions doesn't include size. So we do work hard to talk to you about sizes, shapes, go through that with you in the clinic. We use sizes to get an idea of volume, to try and make sure we get the right implant choice for you. It's important to get that right pre-op, so we encourage you to come back as often as you want to talk about that. And so yeah, revisions. So if there's a problem, you're covered for 6 months. I said that already for the revisions. Yeah, but I'll say, if you put your details in the website and you'll get an email, or if you send a message or something on Instagram, we can pick it up and send you some information about that. Can we remove an ovarian cyst? Yeah, we've got this on the cyst removal page now. I guess on paper an ovarian cyst is a cyst. Fair play to you, can't argue with that. But the answer is no. I mean, it's inside the abdomen, so it's plastic surgery. You're welcome, Georgia. Plastic surgery is one of those ones where you operate on any part of the body, but it's all superficial. It's all skin and fat. We don't really go into the body cavities, so we don't really go into the brain or the lungs or the abdomen. So the surgery is very much skin and fat. It's soft tissue. It's changing the shape, plastikos, changing the shape of the body. So we wouldn't go into the ovary and remove an ovarian cyst. That would be a gynecologist. So that would be a different type of doctor who would do that sort of stuff. Slim Sue, what you got? Is there a risk of keloid scarring with a breast reduction? Yes, there is, Slim Sue. I wouldn't say it's a huge risk. There are certain areas, certain parts of the body which have got a high risk of keloid scarring, shoulders, sternum. Breast reduction is not a high risk area, but it has happened and it can happen. It's higher in certain skin types, so darker Afro-Caribbean skin types. It's increased, or at least hypertrophic scarring, which is like a milder form of keloid scarring, if you like, is increased if there's a delay in the wound healing, particularly on the horizontal scar, which is fortunately more hidden than the scar that's around the areola and down. But still, you can get it in the scar that's around the areola down. And certainly, if you've got a history of keloid scarring, if you've had keloid scarring in the past, that's something that I would worry about. And I would say to you, yeah, I'd be worried about that. There's not an awful lot you can do to prevent it, apart from just saying, look, we'll treat it if it happens. There's things you can do to treat it, and we do treat keloid scars, but it would have to be put into the mix of whether you're going to take on surgery, in terms of risks versus the benefits. So it'd have to go into a risk if you are prone to it. If you're not prone to keloid scar and you haven't got a skin type that's prone to keloid scarring, I wouldn't be overly worried about it. I'm not saying you're not going to get it. I'm just saying the chances are not high for that for a breast reduction operation. It's more for the sternum, this sort of area, and shoulders. Earlobes often get keloids. The top part of my stomach has a loose skin. Do you offer a reverse tummy tuck for that? Well, yes and no. Well, yes and no, not even yes and no. I suppose yes, not even yes and no. Yes, we do. I've got to be honest with you. So reverse tummy tuck is extremely rare operation. You're welcome, Sue. I'm trying to think of the last time I did a reverse tummy tuck. I don't think I've done one since I've had the clinic, which is 10 years. So it's not a common procedure. And it's basically the same as a tummy tuck, but it's at the top. So you have a scar underneath your breast, joins in the middle. And it's for people with a significant overhang in their upper abdomen. It would have to be a significant overhang. It wouldn't be just a bit of loose skin. I mean, a bit of loose skin, I would probably be more along the lines of liposuction to try and take out some of the fat behind the skin and hope that skin recoils. Or possibly just saying except the loose skin, because it's quite, although the scar is kind of hidden like a breast reduction scar is hidden, it joins in the middle, so it's not hidden there, so you get that scar. So it's not a great scar, and it's quite a big op, but yeah, it can be done. But as I say, it's put it like this: a lot more people think they need it versus those who actually end up having it, because it is a rare. It's usually for massive weight loss patients, and it's usually for people who've had a tummy tuck, because the lower abdominal excess is pretty much always, I would say, worse. Not really seen anyone with more up, certainly enough upper abdominal excess to warrant a tummy tuck who didn't have lower abdominal excess to warrant. Sorry, the upper warrants a reverse, and they haven't got enough in the lower to warrant a normal tummy tuck. So the lower abdomen is always worse. So you normally do a normal tummy tuck first, and then if there's a sort of big hanging fold of skin in the upper abdomen, then you could consider a reverse abdominoplasty. But again, that is my view on it. You might find some people who've got lower thresholds to do reverse tummy tucks. I don't know, but I've got quite a high threshold to do a reverse tummy tuck, and I'd be more inclined to do liposuction. I'd just say, look, but it's loose skin. I don't think it's worth doing a reverse one. It's my sort of go-to bit of advice. Do we offer liposuction to the upper arms? You know what? I don't do as much liposuction as you might think I would. You might think plastic surgeon, they're in there doing liposuction all day long. I do like doing liposuction. I do. I love it. I do. It's great. Tiny incisions. Don't have to worry about wound healing. It's very satisfying seeing the fat come out. The problem with liposuction is it doesn't remove skin. And so I'm wary about where I do liposuction. Hips and flanks, male chest, a lot of people want it on the arms, a lot of people want it on the abdomen, a lot of people want it on the inner thigh, and I tend not to use it on those areas. Reason being, the skin doesn't recoil. So I worry about not getting a good result, because the problem with liposuction is the equipment's expensive. It's an expensive procedure. It's not a cheap procedure. And if you have an expensive procedure and have an average result, you're not going to be happy. If you have a cheap procedure and an average result, you're probably going to accept it a bit better. So I tend not to do liposuction to the upper arms as a rule. I wouldn't never say never. You can do it, and I could do it, but I wouldn't tend to do it. Now, there are assisted forms of liposuction, things like laser, and there's loads, smart lipo, and anyway, they've got some kind of energy associated as well as the liposuction. So I use power-assisted liposuction, which means the machine goes backwards and forwards, and it just sucks the fat out. The energy type liposuctions have got some kind of energy that's delivered to the fat to sort of dissolve the fat before you suck it out. Good thing being that they use smaller cannulas, more likely to do it under local anesthetic. And they also say because it's delivering energy to the fat, it might deliver some energy to the skin, and it might cause some kind of skin retraction. So those assisted forms of liposuction do say that they form some degree of skin retraction. So they might be the sort of ones that will be more appropriate for the areas that I tend not to do liposuction, like the arms, the abdomen, and the inner thighs. These are all areas I don't do liposuction as a sole procedure because I worry about there being excess skin there and it not looking good. Whereas if you, and I think excisional procedures are better, but I completely understand that a lot of people don't want an excisional procedure because an excisional procedure means a big scar, and an arm reduction, big scar down the arm, you don't fancy it, and I completely get that. So there's definitely a market for a non-scarring, if you like, procedure for the arms to sort of tighten the skin. But I have struggled a bit with getting it with sort of recommending just liposuction without taking the skin out, because I worry about there being hanging skin there, and you really need something that's going to tighten that skin. And so maybe these assisted forms of liposuction would do the trick, but you probably have to speak to someone who does them, because I don't do them, to see whether that would be something that's worthwhile looking at. But it's definitely an area that needs something, because I think there is a lot of people who don't want an arm reduction but would like their arm of their skin tighter, and it's a gap in the market for show. So this is one that came, and it was on Facebook. I think there must have been a little sticker on the Facebook story that said asked a question. So when I clicked on the little bell on Facebook, it said, question's been asked, but it had half the question and then it had ... And I clicked on it and it just took me to the Facebook story picture. Couldn't find the question. So I think the question is as follows: can you correct grade 3 inverted nipples without cutting the milk ducts? I think that was it. If the person who put that question wants to clarify that and say it wasn't that, then come back at me. But I think that's what they were saying. So basically, yeah. So first of all, different types of nipple inversion. So essentially, it depends on whether it comes out sometimes or if it comes out never. Whether you can coax it out or not. And the more likely you are to coax it out. So if the nipple's sometimes out and sometimes not out, then you could look at things like suction cups, the Nipplet device, and what have you. So that was something that the more deeply inverted it is, and if it's deeply inverted all the time, then you would worry that suction cup's not really going to stretch those ducts enough. Now, the reason that you've got an inverted nipple is because the ducts are shortened, the milk ducts are shortened. And there's two ways to correct an inverted nipple. The best way to correct an inverted nipple is by cutting those ducts. Now, there is, whichever way you do it, there's a risk of it coming back. So there's a risk of it coming back if you use a suction cup. There's a risk of it coming back if you do surgery. Now, if you cut the ducts, you're reducing your risk of the inversion happening again. Now, having said that, when you cut the ducts, there is a space which can fill up with scar tissue and put it back down again. So there is still a risk it can come back again, but it's less of a risk, and we try and bolster it up and put some sutures into it, but it doesn't come back down again. But of course, if you're cutting the ducts, then you're not going to be able to breastfeed in the future. So that a lot of people think, oh, I'm not sure about that. Like this person here saying, can you do it without cutting the ducts? Well, yes, you can do it without cutting ducts. You can do it by keeping the ducts intact. And you just tease them up in a line in the line of the duct. So you're not cutting the ducts. This way you're going in the line of the duct, tease it up, tease the nipple up, and then you have to hold it up somehow. So you can take a flap of skin from the areola, put it on either sides, and try and hold up the nipple that way to sort of bolster it up. The bad thing about that is, number one, there's scarring on the areola, whereas when you cut the ducts, you don't really have any scarring on the areola. You have a tiny little incision at the base of the areola you can't really see, whereas this has got sort of radial scarring going out, which you might be able to see. It usually blends in pretty well. But the main risk of that is because you're not really cutting the ducts and you're just trying to pull them and stick some tissue in to stop them from dropping down. There's a higher risk of recurrence or incomplete correction. And so if they're deeply inverted, eye moving, and again, this comes back to what I was saying at the beginning, everyone's got their own views on things. I'm moving away from doing that, to be honest with you. I'm like, I don't, it doesn't look as good when you don't cut the ducts. It's got a dent in the middle, it can pull back in. As I say, yeah, that can happen when you do cut the ducts. So it's even more of a risk when you don't cut the ducts. So I would be questioning whether it's worth doing surgery if you're absolutely sure you don't want your ducts cut. So if you don't want your ducts cut, and you think, I want to breastfeed now, you might not be able to breastfeed anyway, given that you've got a significantly inverted nipple. But if you absolutely sure you want to try, I would say just don't have surgery and see how you go. And then once you've finished your family, what have you, maybe think about having it done, because I think the most long-lasting way is definitely to cut the ducts, and the most sort of I'm not sure if impressive is the right word, but the most complete correction is with cutting the ducts, in my experience. Elaine, how are you? Missed the last few weeks. I've been in theatres too, on placement. Look at you in the theatres. What's going on here? There's a little question. Oh, here we go. We've got 2 questions. Wow, this is, start something big. Nothing's happening on Facebook, but Instagram's all going. It's a question from someone. 6 days post-op, how to help a stubborn implant drop? Other side is fine. Yeah. 6 days post-op, don't worry about it. Again, back to the thing like I said at the beginning, that everyone's got different views about stuff, and stick with your surgeon and what your surgeon's view is. Some surgeons who've got straps, you put a strap across the top, and some people give you bras, and the bras have got straps and all that sort of stuff. We sometimes use a strap, hardly ever, to be honest, hardly ever use the straps. I don't know, I'm not saying they don't, I don't know if they work or not. Massage can help. 6 days post-op, I wouldn't go too crazy on it, to be honest with you, and I wouldn't be too worried about it. They're always a bit high to start off with, and one's always worse than the other, whichever one it is. There's always a bit of asymmetry. So at 6 days, I wouldn't be going too crazy on it, trying to get it to sort of drop. I normally say that 3 months, really, for things to start to settle as well at 3 months. So at 6 days, I won't be too worried. Talk to your surgeon, keep close with your surgeon. You can ask them about the straps, whether they think the straps are good, and you can ask them about massaging. They might not want you to massage at 6 days. I don't know, that might be a bit soon for them. But yeah, try not to worry about it as well. I do believe there's, psychosomatic has got a bit of a bad name. It's a bit like, oh, it's all in the mind. Oh, they're mad. They've got nothing wrong with them. And I realised this with my back pain. I think there's definitely a link in terms of the mind, like causing the muscles to tense and causing the problem worse, causing your back pain worse, causing your, things to get worse, really worse. So it's psychosomatic kind of sounds like it's all in your mind. I don't think it is all in your mind. I do think it is real, true things like maybe the implant's high or the pain or this or that. And I do think it is important to try. I'm not saying sort of don't worry about it, it's all going to be fine. What I would say at 6 days post-op is don't worry about it too much. And what I normally say to patients is that I can't guarantee it's going to settle. Often I'm like, I think it probably will settle because it doesn't look too bad. I think it probably will settle, but I can't guarantee it. It might not. You might need to have something done, might need to lower it or whatever. But what I can guarantee is at 6 days, this isn't your final result. So your result is going to be different at 3 months, at 6 months, at 12 months. So try not to worry about it today, because in 6 months, it might be something, the other one might be dropped too low. It might drop too low. The other one might drop too low. One might be bigger. So, you might have a different problem. So don't worry about this problem now, because this isn't your final result. Don't know if that's helpful. You might have another problem in 6 months. Don't worry. But anyway, that's my angle on it. Katie, is there any possible complications with implants and being pregnant? No. Nil. Nicht nada niente. The only problem, and say to people that it's different if you're coming to talk about having implants and saying, I'm thinking of getting pregnant. That's a different conversation to someone who's saying, I've got implants and I've just got pregnant. So if you are not pregnant yet and you're saying, is there any problem with having implants? I would say to you, well, don't have implants if you're thinking of getting pregnant. Because if you get pregnant, your breasts will get bigger. They might stay bigger. They might get smaller. They might droop. Things might happen to your breasts. So you're better off waiting until you've finished your family before having implants, because you could have implants and your breasts will change. If you've already got implants in, there's absolutely no problem with getting pregnant and having children and breastfeeding and all those sorts of things. People are about silicone and silicone in the milk and things like that, and they've got it in the silicone teats you give the children, so they ingest silicone from the teats. So there's no problem with having implants if you and then getting pregnant. The only problem is your breasts might change shape, they might change size, and that might mess up your operation that you've just paid thousands of pounds to get your breasts how you want them, and then you have children and then they make them bigger and they stay big or they droop or they get smaller or whatever. So you might need to have something done to fix that, or you might not. You might say, I'm happy, I've got my children, I'm happy, and who cares, that's fine. But that's the only issue about having children with implants. So as I say, if you haven't got implants in yet, I would probably say to you, wait. If you've already had the implants put in, I would say to you, don't worry about it. Have a family, go for it, enjoy, don't worry about it. 2 questions on the sticker. I think that's got to be a new world record. Thank you for that, you sticker questioners, questionees. Questioners, am I the questionee? You're the questioners? I don't know. Anyway, digressing. Any more for any more? Anyone? Give it a couple of minutes, shall we? It's like when before you start the talk, there's no one at the talk. Give it a couple of minutes before we start. People are probably late. People are not arriving yet. Yeah. Give it a couple of minutes, shall we? Let people park and find. Yeah. No one else is coming, are they? This is it. Face it, Jay. This is it, mate. No one else is coming. There's no more questions. Oh God, there is a question there. Yes, there's a question. Right, what we got? Is there a possible? Hold on a minute. If you develop mastitis, could that affect the implant? Oh, look at that! Look at that! Quality. Look at that. Is there a problem with it getting pregnant? No problems at all. What about if you get pregnant, if you get mastitis? Yeah, okay, good point. Blimey, maybe should I put that into my maybe I should revise my implant and pregnancy question. Well, yeah, is the answer. So I guess if you get pregnant and you breastfeed, you're going to have a higher risk of mastitis because you're less likely to get mastitis in a normal. I mean, you could get mastitis in a normal daily basis, but you're much more likely when you're breastfeeding. And therefore, if you get a mastitis, which is an infection right near the implant, could that then make it implant infected? Yes, is the answer. So that would be a kind of a worry in my mind if you had a implants in and you got mastitis. I think, could it get the implant? Could it make the implant infected? Could it increase your risk of getting capsular contracture? Yes, these are all bad things about having a implant in if you're getting pregnant. Having said that, I still would say that the change in the shape of your breast would be more of a thing. So I wouldn't over egg it on someone who's already got implants in who's going to get pregnant. Whether that's something I should be saying to people before they get implants, if they're thinking of getting pregnant, yeah, maybe I should say. And if you get mastitis, you could get an infected implant. Good point. Wish I'd thought of that. Note to self: who get mastitis? Yeah, didn't think of that. Yeah, that's a good another reason not to have implants and pregnancy. But I think the shape thing is probably more of a thing for me. But backtracking there, trying to justify my answer rather than yours, but both valid. Yeah, well done that. I'll take that on board. Take that feedback. Mastitis could be a problem if you were. If I finished the live, I would have avoided that public humiliation. If I finished early, but there you go. Live by the sword, die by the sword. Put yourself up for this sort of stuff. Going to get called out, aren't you? Members of the public saying, "What about this?" And I'm like, "Yeah, didn't think of that." Well done, Katie. Well done, you. Sticker for that. Deserves a sticker. Anyone else want to pick me up on any of the answers that I've given that were woefully inadequate? Any other inadequate responses to questions, or was that the only one? Yeah, only one at this stage. I'm sure if you review the footage, you'll be able to find plenty of inadequacy in the questions presented. But anyway, yeah. Okay. Well, listen, I've got things to do, to be quite honest with you. Got to pay the milkman and got a lot on, awful lot on. So I can't dilly-dally. So anyway, if there are any questions, I will happily respond to them. But in the absence of and if this comes back as a review thing on Facebook and there's loads of questions and I've been ignoring them, just so you know, on my bit, there's none. I'm sure it's a glitch. I can't believe there's no interaction on Facebook. It must be a glitch. So when it comes on the review and you see all those unanswered questions, it's because it's not showing me any questions here, what I'm seeing. So sorry for all those people on Facebook who are clamoring to ask me questions. I'm sure you're all there, but I can't see you. It's making out as if there's no one there, which clearly can't be the case. I think we all know that social influencer like myself is not going to have like no one on Facebook. I mean, that's just clearly not possible. There must be a glitch in the system. I think that's quite clear. We'll talk to the Facebook executives in the morning and see if we can get that fixed. But anyway, okay. Well, have a good evening all, and wrap up. Early night, I think. It's so cold, isn't it? Just get your book. Got a good book. Got a really good book at the moment. Just can't read my book, I think. But yeah, after I've paid the milkman. Anyway, that is not a sort of double entendre or connotation. Paying the milkman is exactly that. Just got to pay the milkman. Okay, so don't get anything by that before you get writing with complaints. Anyway, so I will see you next week, same time, same place. And yeah, maybe there'll be someone on Facebook as well, but Instagram's a live and vibrant community of Instagram. Thank you. God love you. Well done, Instagram. Facebook, yeah, take it easy, Facebook. Hope to see you next week, maybe if you're around 7 o'clock. Yeah.